All right, hee haw, y'all. We are back after being on vacation for a few weeks. I am still channeling my inner Montana, wishing I were still out there enjoying some time and peace, relaxation, and not dealing with some of the litigations and some of the bizarre things that are going on in the world of healthcare these days. So, as always, I want to begin by saying welcome to our esteemed panel: Paul Spencer, Stephanie Allard, Scott Kraft, Christine Hall, and last but definitely not least, Miss Terry Fletcher. How are you, my friend?
Good. All of us are good, I think.
All right. So, enough with that. Got the hat off, and now people hopefully will take me a little more seriously. All right, so we've got a lot to talk about today. We have many, many topics. I think we're all excited to be able to, get back together, and it's been a while. Hopefully, Paul, Stephanie, Scott, Christine, Terry, you guys have all been doing well. I know we have a lot of topics that have been saved up over the last 3 weeks since we haven't been able to be together. So why don't
Well,
we start?
John,
Yeah, go ahead.
that's true because, I say it all the time and it's kind of like a catchphrase now, but the only thing we can count on is change. So 3 weeks, there's a lot of change, a lot of things that have happened in those 3 weeks.
Absolutely. Absolutely. So let's start off by talking about one of the easier ones. Maybe easy. I don't know. We'll see what people think as we get going on this thing. Um, the G2211. Now, we're not going to get into a whole dissertation on this. We're not going to have a whole long conversation about it. But I think there's some misunderstanding as to who is required to cover the G2211 versus, let's say, who it's optional for. So who wants to take this one? Paul. Let's go
Oh,
with Paul.
I'll take it since I brought it up. So, and here's just a good rule of thumb. Anytime you see a code that begins with the letter G, assume that it's going to be paid by a governmental payer and not necessarily a commercial payer. There are some limited exceptions, but one thing I'll put out there that came out in the latest United Healthcare Bulletin that hit my inbox sometime last week. And I encourage you to sign up for those bulletins because the information that's put forward is fairly important. UHC has announced a rebundling policy where they say September 1st, 2024, effective with dates of service on or after that date. HCPCS code G2211 will be included within the United Healthcare commercial rebundling policy. So reimbursement for those services is basically going to be included in outpatient management and evaluation and management services and not separately reimbursable. So that basically sums it up. We are beginning to hear of other commercial payers that are going to be following suit, but surprise, surprise, UHC is the first one to put their toe in the water of denial, and G2211 will not be covered by UHC as of September 1st.
I'm seeing it in a lot of the commercial plans as well because I have a lot of pediatric docs who are trying to bill for it, which I'm like, how did you even come on your radar? It's a Medicare HCPCS code. So
Yeah.
they're like, well, my doctor who talked to my doctor who told me about it, who had a friend of an uncle. Okay.
The well-informed colleague. We've been
Yes.
down that road.
Yeah.
Yeah. Maybe for ADHD in a perfect parallel universe, but not so much.
No.
All right.
Yeah, the one
Any
thing,
other thoughts, Scott?
yeah, the one thing I would add to that, interestingly, with pediatrics, I'm seeing that a little bit myself, the use of G2211. And I think, as we would say with a lot of these codes, if I were going to start billing this code for a non-government payer, I would want to have a better understanding of what that payer's policy was. I think sometimes, I've certainly seen groups before go down this path where they say, well, let's just kind of, put it on everything and see who pays for it and who doesn't, and at what levels. And so, whether it's payable in pediatrics or not, certainly there are complex patients, within pediatric specialties in some cases, where it would be relevant. But I do think you do have to make sure, is your payer bundling it or unbundling it, and under what circumstances. So, I can't speculate on UHC's announcement, but my guess is a lot of providers just started slapping this code on everything and seeing what stuck.
Yeah.
And UHC is saying, stop wasting everybody's time with this.
Yeah. Pretty much. I think what's really going to be interesting with this, and I mean, I know that we have a lot of topics to cover today, but one of the things that especially Noridian puts out there all the time is that Medicare has to be your lowest fee schedule in your office. You can't charge Medicare more than you're charging regular patients. And so I wonder where this fits into that, where even though you're not charging more for the visit itself, you are charging in excess for something that other payers are saying is inclusive. And so it seems like it's almost in reverse, where I could see Medicare or CMS coming out this fall with a new fee schedule going, well, we've kind of revisited it because we thought it was going to be 38%. Now we're seeing it be 90%, slapped on. And we don't have the budget for it because they did not allow for all of this billing for it. So I think it's going to be interesting.
I wish some of these, DraftKings or some of these apps, you could bet on the odds that it would be over 38%, right? Like
I
I would have
know, right?
taken my entire life savings and betted on that.
I know. Oh, there's so many things. I'd be like, oh, I wish that was a Jeopardy question. I would have cleaned up. Yeah, no, go
So I
ahead.
guess one of the things that the listeners can take away from this part of the discussion is when you are creating your policy for the G2211, make certain that you are focused solely on CMS guidelines and those of the Medicare administrative contractor. Because again, if a commercial payer covers it, it may be few and far between. You can always attach their medical coverage guideline to your policy, but focus on CMS guidance when it comes to, and most specifically, the LCD to your specific region to ensure that you're in compliance with the frequency, the number of times the service can be rendered, the documentation requirements, etc. Terry, you bring up an interesting point also. It's on topic, but it's a little off topic because you started getting into the discussion about fee schedules and making certain that your fee schedule, you are not charging Medicare beneficiaries greater than what you charge anybody else. So there's something that it's called the oh my gosh, I should have stayed on vacation. Um,
I know what it is, but yeah, I know. I can't think of it either.
no, it's called the Most Favored Nations
Most Favored
Clause.
Nation. Yes, yes.
Oh God, thank God that one came back to me. That would have been terrible. All right, so the Most Favored Nations Clause. One of the things that I always advise our clients is to make sure before you sign a contract with an insurance company, make sure you understand what's in your contracts. I can't tell you how many times I review contracts for a provider and their group, and I explain to them that you can't do what it is that you're trying to do, or you're out of compliance with what's required. And they're like, well, how do you know that? I'm like, it's in your contract. So
Right.
one of the things that I always advise clients to do is when you're going through the credentialing process or the contract negotiating process, put a single strike line through certain things that you don't want to have in your contract, either because you think it detracts from the practice, it financially impacts the practice in a negative way, or it's something that you just know you're not going to be able to comply with because it's such a ridiculous ask by the insurance company. But most importantly, and David Zetter, one of my favorite people, David Zetter and I do quite a bit of work together where I have clients that are going through the contracting process. He's absolutely unbelievable. He knows this stuff inside and out better than anybody I've ever come across in my professional career. But David always says the same thing. How can you engage in a meaningful way and know what the rules are if you don't have the rule book. If you don't have your contracts, reach out to the payers that you're participating with and demand them. They are obligated to provide those to you. So stay on top of that stuff. But I always strike out a most favored nations clause, because what it basically says is, if you have two insurance companies and you contract with insurance carrier A for this price today, and tomorrow you contract with insurance carrier B, and their price is is lower, or it's more than what you're getting from the other payers, by contractual obligation, you have to drop their contract to your lowest payer's negotiated rate. That's what a most favored nations clause is. They were out of contracts for a lot of years through the early 2000s, and they just started making their way back in probably the last 5 to 7 years. So be careful. Again, get the rule book, which is your contract from the payers. That way you always know what's expected of you and what you should expect of the payers. All right. Anybody else has anything else to talk about with the G2211?
No, not with G2211, but I have an
No.
example of what you're talking about. Twice in the last 2 weeks, I'll come right back to you, Scott, I swear, is that I've had providers coming to me and asking, can I charge an annual fee to my patients to process authorizations, prescription drugs, send referrals to other providers? And first thing I said was, do you have a contract? Are you participating with this insurance? Because that's part of the conditions of your contract. And they said, I don't know. I've never read the contract. I said, well, that's a huge problem. And the fact that you're talking about it, Sean, and that this has happened just in the last 2 weeks, twice, right? I think that we need to drive this home, that providers need to understand what they're agreeing to in those contracts, because ultimately they're responsible for that. Not just the administrator, not just the practice manager, but the provider understand what they've agreed to, what they've signed.
Yeah, Scott, I know you have one more thing on the G2211 that I wanted to chime in.
Oh, yeah. So I did want to throw this in. I was asked an interesting question last week about G2211. And the question was, am I auditing it for revenue or compliance? And what the questioner basically meant was, if I'm doing an audit, will I add it to the encounter when the provider has not billed it? And I thought about that. And one of the things that I have found myself doing, and I've suggested it to some of the people I work with. I mean, first off, the answer was a qualified no. And what I meant by that was, the definition of G2211 in some ways is, it's one of those definitions where you're asking the provider to weigh in on how they feel about the nature of a provider-patient relationship. And so my approach to it has been that on a single claim, like if I'm doing a 10 chart audit and I see G2211 is not there, but I say, well, geez, it's a Medicare patient and they're managing all of these things, I'm sort of disinclined to add it. But I will write a comment about, like, this is a case that may fit the parameters of the use of G2211. And the point I'm trying to make here is and I think it's somewhat related to this idea of, let's just slap G2211 on all these different payer encounters. I think it's important as an organization that you are developing what you consider to be your best use cases of G2211 based on your patient population, and trying to apply that in terms of physician or provider education in a proactive way, versus coming in and pulling 10 charts and doing an audit and saying, hey, in these 2 charts, I added G2211. Because to me, I think it's really important that the provider understand, what the definitions are, what the potential risks are. I mean, even when Paul had mentioned the pediatric cases, one of the questions that came up with me with a pediatric group is, there's really 2 definitions of G2211, right? It's the ongoing care for a patient's serious or complex condition. But then the first part of it says, serve as the continuing focal point for all needed healthcare services. So if a patient's pediatric and they're, 2 or 3 years old, hypothetically, and the payer's covering it, and you got all the otitis medias and fevers and all these things, and the kid's in there like 4 times a year, Do I think this is necessarily quote unquote serious? No. But if the provider comes to me and says, well, I am the focal point for all of these conditions and I'm seeing this kid 6 times a year, it goes back to my rule 1A of auditing. If I tell you can't do something, I have to point to the reason. And, so I do think that becomes important, because I think the definition of G2211, as we've talked about in this podcast before, is so broadly and blandly written that it's resulted in this. It's sort of a problem of their own making, where it's created this free for all, where the provider says, well, I'm the one who sees the patient all the time, like all they have is recurrent sinusitis, but I'm the one who sees them. And so I do think it's important, rather than asking the auditor to look at 10 charts and slap it onto things or take it off of them, this really is about the provider understanding the definitions and how they apply them to their own relationships.
Right. Let me just add just a final one on that. I've already had some payers, and we're not even in full 6 months of the year, that have questioned the medical necessity of the G2211. And so one of the things that I have used when it's available to not just fight a denial is if the patient's also enrolled in chronic care management. And if they are enrolled in that, I said, well, because this is a longitudinal relationship, how do you support that? I said, well, actually, the patient's also in chronic care management because of their 2+ chronic conditions. They have a possibility of decompensation or rehospitalization, the definition of the code, which shows that this doctor not only, is taking full responsibility for all the needs of this patient, but also the complexity of the nature of their care. I had come up with one wrinkle, though. When I do see that actually the patient could qualify for it, but it is, to me, it's not really serious enough to slap the code on. I've asked the provider, why aren't they in CCM if you also believe that this is that chronically a problem? And they said, well, G2211 doesn't mean that the patient doesn't have to authorize it, but they have to voluntarily accept CCM. And so I don't have to ask their permission to bill it. And I'm like, and I'm out. So I know you said that to me out loud. Whoa. So to me, that was more about money than it was about the patient. And Sean, with that, let's move on to the next one. I just was like, you've got to be kidding me.
Yeah. So, I want to move on to talking
yeah, let's move on.
Yeah. I want to move on to talking about electronic health records. For a lot of reasons. I have a client who has recently transitioned over to a new EMR. He had been on one for a long period of time. It was not a very good one, but it did what he needed it to do. He was very comfortable with it. He was able to build a lot of smart phrases. He was able to open to free text boxes and put a lot of critical information in there about it. And he went from this, I don't want to call it a lower end, but this more user-friendly EMR version that was more specific to his specialty, excuse me, to a more mainstream, more recognized name. And now his documentation is suffering something significant because it is lagging in a lot of areas. He's really confused because this EMR, even though it's supposed to be one of the better ones out there, if not one of the best ones out there that they always brag about, when it comes to evaluation and management services, it's still using bullet points. It's still using body areas and organ systems. It's still relying on counting, review of systems, past family social history. I sent it was the first email I addressed when I got back to my desk this morning at 7 a.m. and sent it to the trainers at this company. And I said, guys, gals, listen to me. We are no longer utilizing 95 or 97 documentation guidelines. Why are you building templates or giving templates to my provider that are based on these elements? Everything right now is based on what a clinician believes to be as a medically appropriate history and or examination, which leaves it up to them. Now, if you want to give them the option of selecting body areas and organ systems and, selecting elements of the review of systems and past family social history, that's fine. But it should not be calculating a level of service like what it's doing right now. And we need more free text boxes for the providers. So I know, Christine, you have a lot of thoughts about these EMR systems. And obviously, I don't ever want to disparage a company. I don't ever want to call a company out. That's just not how I do things. Not because I'm worried about them coming after me, for liability reasons, but it's just not the way that I conduct myself. And some of you have your own thoughts and feelings about these EMR systems, and some of you probably know who I'm talking about. So I don't even need to mention it. So let me go ahead and turn it over to Christine, and let's get some commentary and let's get some of your thoughts on this.
So I have mentioned this so many times here on the roundtable and other areas that I've spoken on. Your EMRs are a tool. That's it. And I think that a lot of providers, they have this false sense of security that if the EMR is telling me to do it this way, then that's the way that it should be done. And unfortunately, a couple of things happen in that respect. One, they're over documenting when, again, I'm not a clinical person, so I can't tell you how much documentation should be in every record, but I can tell you that more doesn't equal more money. So if you want to do head to toe on everybody and you want to, spend half an hour with every patient, that's totally on a clinical interpretation. But remember that the EMR, that tool is just there to help you make sure that you've captured everything in that note, from a reimbursement perspective, from a legal perspective, and from a continuity of care perspective. And I think they need to go back to that mentality of focusing on what needs to be documented to meet those three requirements. How do I support my payment? How do I support myself in litigation? How do I support myself with continuity of care? I win the lottery tomorrow. I buy an island. I retire. Next doctor comes in. How did they take care of this patient, right? Those types of things. So regardless of what EMR it is, it doesn't matter. You have to make sure that you're taking ownership of your documentation. You're taking ownership of your knowledge of how you get paid. How do you calculate those evaluation and management visits? So that's kind of my soapbox. And it's not changed in any specific way, but remember, it's just a tool. Don't be a tool. Use the tool. And sorry.
That is I will be using that in some context going forward.
Don't be a tool. Use the tool. I like that
bumper sticker.
That was really good, Christine.
Well, Stephanie, you had some thoughts on this, right?
Yes, and I wanted to mention too, so as you were talking, Christine, this reminded me, and I think the conversation took place during our virtual NAMUS conference that we had last month. But we kind of had this whole discussion about the fact that people who are working at these different software companies do not necessarily have the compliance background. We don't know if they have anybody from compliance giving input. And a lot of times when I find issues during audits, I actually ask to speak to the EMR vendor if I have a close relationship with the client that's ongoing, or if it's just a one-off audit and I'm working with them one time. I basically give them a list of different areas that they need to go back to their coding vendor, or not their coding, their software vendor with. So first and foremost, remember, just because your system is pushing you to do something, or like Sean said, because the system calculates a certain way, doesn't mean that you're covered. It doesn't mean that you're going to be fine in an external audit. And, there's one particular one that I have issues with that keeps coming back and back and back. And of course, it popped up again last week. And it was a situation where if the provider is sending a prescription for an over-the-counter medication, in the system, they are following 2021 guidelines, but it does spell out, the different buckets that they calculate towards the level of service. And every time it's coming out as prescription. So if they do, ibuprofen through the pharmacy, or some kind of topical gel through the pharmacy, those are available over the counter, but the system's automatically going up to moderate. And, one other thing I want to mention, and I know we've talked about this some before, but it becomes a huge compliance issue, because when this particular client of mine, this is not the first time they've had issues with their EMR system and the vendor not really following straight with compliance. And every time they go back, the vendor doesn't want to change it because they're not making it individualized just for that practice. It would change it in their entire system, and they have thousands of clients. So it leaves it at a point where my client is now having to watch their back. And yes, they do have some coders, but when providers are largely responsible for their own coding, that creates a lot of problems in the workflow, because the system's going to say a 4, that provider's supposed to know to go back and change it to a 3, and we know that that's not going to happen. So it's really quite the issue.
Yeah, I've talked to providers all the time. I say, just because your system spits out a calculated code, you still have to be able to override it,
Absolutely.
because those systems overcode and undercode. I'm dealing I'm dealing right now with an audit from from UHC, one of the major payers. I mean, they don't care. They use me all the time. And basically, this doctor undercoded because he didn't want to get in trouble, and every single patient is a level 2. This is a cardiothoracic surgeon.
Yeah. So listen,
So and
ask
he's
me-
getting in trouble.
yeah. So people ask me
Glad
all
you
the
say
time.
that, Terry.
Yeah.
We need
Pe-
to highlight that.
People
Yeah.
ask
Well,
me all
remember
the
that
time,
sorry.
and they're always saying, "Yeah, it's okay," and they're always saying to me, "Listen, if I just, I understand my documentation supports a higher level of service. I get it. I understand the acuity of the patient. I understand the medical necessity, the appropriateness, the reasonableness. I check all of the boxes. But the truth is, if I select lower levels of service, I'm going to be off the radar. They're not going to detect anything. They're going to leave me alone. I'm not going to have a problem." Folks, that's not true.
No,
You are
and
impacting, you are
the-
impacting the physician distribution analysis, and
and
you
that's
are
what the
skewing
payer said.
numbers.
They said, you're making us work to figure out why all your patients are minimal risk, why everybody else's patients are moderate to high. So, especially the specialty, it definitely triggered it. But
Terry,
I see that a lot.
Yeah.
aren't
plus,
many of the laws that we have in place, the False Claims Act, anti-kickbacks, the Stark Law, aren't those to preserve fairness
Fairness,
in
yes.
reimbursement?
Mhm.
They're
And if
not
you've
about
got
just
right.
upcoding. They're about coding correctly,
So if you've
recording
got one
correctly.
doc billing the 212 and the doc next door is billing appropriately, wouldn't that maybe skew patients towards the cheaper doctor? And isn't that
Yeah.
what the laws are there to prevent?
It's
Yeah.
it's
Well, it
it's
could if there was an
providing it, yeah.
advertisement.
Yeah,
If there
it's
was an
provi-
advertisement that you come to me and I have the lower costs between every. See, what it really comes down to is data analytics, right? Every single insurance company uses data. They use the data to identify aberrants. They use it to find billing patterns. They use it to find a whole host of utilization issues that they can target an investigation or an audit towards. What I tell providers all the time is stop trying to figure out what you should be coding to, avoid risk, and code what
What
you
you
have
did.
performed.
Right.
If you did a high level of medical decision making and your patient resulted and that patient resulted in having to go to an emergency room for stabilization services, or they wound up being sent over to the hospital and they wound up going for an emergency appendectomy or a gallbladder removal or whatever it is, you should be billing based on the acuity of the patient. You should be billing based on the amount of time. Remember, we are not beholden to any guidelines any longer that tell you got to check the boxes.
But Sean, a lot of these providers don't understand that. And Paul, I'm going to send it to you after this because I know you see this in CERT audits as well. Is that one of the things that drive me crazy is I have a lot of UC clients, so urgent care, and they don't have MRIs. They don't have higher, diagnostics. They have X-rays. and they can do a quick swab, for strep or something. And so they will send the patient to the ER saying that they need to have a CT scan for precautionary measures, not because they need it, because they don't have it. And they're like, because they escalated that to the ER and to the hospital, that's automatically level 5. I'm like, no, it isn't. You said you don't even suspect that there was a head injury. You don't suspect that there was a high risk problem. You just want, for precautionary reasons, because you're not an emergency room. You're an urgent care that's only right now being managed by a nurse practitioner, not to discount what they do, just saying. They're just, they're trying to say because they sent the patient to the hospital that obviously now it jumped from a level 3 to a level 5. And Paul,
That's not an escalation in care.
Yeah,
not right.
That's a convenience, not an escalation in care.
Yeah, it's not a decision for hospital level of care. It's a decision for hospital level of diagnostics, which is completely different. Yeah. And one other thing that I'll add about the EMR issue, and I think everybody has really made it already. And then I'll throw it to Stephanie because she has an additional point. I mean, I was telling people to avoid the tools that spit out a code back in 2008 when those systems were able to spit out codes in 2008, because they still weren't calculating it correctly, even when they had a number of bullet points and boxes that were checked and it counted up to this number of review of systems or this number. It still can't. It can't calculate medical decision making. It'll never be able to calculate medical decision making based on acuity.
Okay, so I'm going to take a step back to what Sean was saying really quickly, because I've seen a big issue with this in family practice. So with residency, especially after the pandemic where we no longer have the waivers that we're talking about level of precepting, I now am doing audits as recent as having to meet with some physicians last week about this, where they're wanting to bill everything as a level 3 just because that gets paid when they don't physically precept. And, it's a systemic problem in these practices because it starts with scheduling, the volume of patients, the number of appointments that they're expected to see throughout the office. But we have to remember that when we're looking at the teaching physician guidelines, they state that it's only the patients of that low complexity or less that are able to qualify for that lack of precepting, of physical precepting. So when Sean was talking about data, that's actually a conversation I had with a physician last week, because, they're like, I'm trying my best. I'm going to try to do this. And I was talking through with the compliance officer as well at the same time. And I said, listen, this type of thing happening could be seen through your data alone. You have a level 3, you have a GE modifier, but you have multiple chronic diagnosis codes. I could look at that as an auditor and not even have to look at the notes to tell that that's probably an issue when everything's down coded to a 3. And, every single teaching facility that I've worked with, including the one I started in as a coder, has that awful process in place where you just downcode to a 3 because you want to get paid something, and it's just beyond non-compliant. You can't do it.
Well, I have the same thing happening with injections right now. Trigger point injections, they pay terrible. And so a provider said, well, the patient's scheduled to come in for a trigger point injection, but they only giving me $42. So I'm just going to bill a level 4 because I can get $145 and it's still a moderate level of service. And, I swear the face plant emoji was made for us. I just think that was for, healthcare people. It just, you can't bill something based on what you get paid. You have to bill based on what you do. And I see surgeons doing this too all the time. They're like, well, this is actually what I did, but this pays me more, even though it's a lesser service. And we're not even talking upcoding, well, the E&M from the trigger point was, but sometimes what the doctor feels is a lower service pays more than what is actually a higher service. And I know we've all seen that. And it's very frustrating because they think that they're not on the radar, like Sean said, just because they're billing a lower service. But remember, now you've got the facility coding to deal with. You've got what was actually authorized to deal with. And talk about red flags up and down the sidewalk on that, just because you don't realize it's not just about what you did. Remember, there's surrounding services.
That's what I was going to say, Terry. Get out of your bubble. Don't you
Yeah.
think that the payer knows that they paid for prescriptions, they paid for imaging, they paid for labs, and you're billing a 213 for multiple diagnosis, and the pharmacy just filled all of these prescriptions for this patient based on your prescription that you've given that patient. Like, think beyond your own bubble. All these other people are submitting claims and showing how sick this patient is or what is exactly going on, and you don't match. Either you're a bad doctor or
Something's
there's
going on.
something fishy, right?
Right. All right. So again, I think another great topic, another area where we could continue this discussion for another 30 minutes. But we have another topic. And Christine, I want to come back to you real quick to talk about a course that you taught. And I actually got a chance to listen to it. I asked myself why I was sitting in on that session other than the fact that you were my friend. But when I heard you start to explain things, it started making me itch because you start
I don't know how I feel
to,
about that, Sean.
well,
Yeah.
I think you know where I'm going with this.
Yeah.
Because when you start to dissect a CPT code and you don't just look at it in the grand scheme of things, but you actually drill down into the specifics and really what it is that the code states, and especially when you start looking at things like CPT assistant, you start looking at other coding conventions and other guidelines that are available, you start to recognize that there's something much more than just that description of the CPT code. And the course that you taught was called The Anatomy of a CPT Code. And it's really kind of fascinating. Either that or I'm just a coding nerd. So
I'm fascinated with it too. That's why I developed that course, was that, there are already so many things built in. Can you have an assistant at surgery? It's already built into the code. It's not a question if the doctor feels that they need to have somebody there. From a reimbursement perspective, that code already states yes or no. Can you have multiple surgeons? Can you do multiple surgeries with this other code? It's already built into it. How do we get paid with multiple procedures? That's already built into it. There's so much that is already in that structure of the CPT code. And I find it interesting that a lot of practices will say, well, let's just throw some modifiers on it and see how it affects that code. The code is already has its own structure to it. Throwing that modifier on it isn't going to change that, isn't going to affect it. If anything, it's going to make the payer know that you don't really know what you're doing. You're just throwing darts against the wall to see if something sticks. So I encourage everybody to really figure out how you can learn each code that you bill in your office, what's already predetermined about that specific code. Don't try to monkey it.
Yep. So, in addition to all of that information, which is helpful, as it applies to assisted surgery, I'd also, even though Medicare is basically, they draw a red line in the sand as to this is where the assistant belongs, this is where the assistant doesn't belong, and no amount of modifiers is going to fix that. I would, for commercial payers, at the very least, look at the American College of Surgeons guidance on assisted surgery, but meet us halfway with the documentation and tell us why that assistant was needed and what key portions of the procedure are there. So that's my first point. The second point is that when we look at a CPT code, we're looking at a few different indicators as far as the assignment. It's like, the most important being, does it match what was being performed? And I will make the point that the AMA could be of help with this, because one piece of information that is not publicly available behind every CPT code is what is included as the key components of that code, spelled out in a literal form. But the AMA keeps that information in a black box and won't share it. So we can pull out a number of different indicators as to what is behind that code. Not only the description, if you get a coder's desk reference or you have coding software that provides a lay description, you can get a little bit closer. And when we look at the time spreadsheet that's put out with every fee, Medicare physician fee schedule every year, we can kind of look at the amount of effort from a time-based point of view as to what goes into pre-preparation, inter-service time, and post-operative time, and what that post-operative course looks like. But the AMA could make it a lot easier by just saying, this is everything that we would expect to see for this procedure, and we have this saved, but we're not going to show it to you. It's like, well, isn't that wonderful?
Well,
Terry, did you have something that you
Yeah,
wanted to
Terry.
add to this?
No, go ahead.
The incident 2 you were talking about, and then I think in one of our email streams behind the scenes, I had mentioned that even the indicators on CPT codes tell us what procedures are ancillary staff allowed to perform and bill incident 2. Like the administration of an injection already has an indicator that says, okay, this is allowed to be done by. But there's other procedure codes like, I don't know, brain surgery that don't allow that to be done incident 2. And that's part of the CPT code from a reimbursement perspective. So even if you took state scope of work out of the picture, which we would never do, of course, the code itself says, yes, you can have someone do this and bill for it. No, you can't have someone perform this and bill for it. And I think you were having something about that, Terry, with incident 2 services.
I was, only because I think people miss the fact when they hear the word clinician, they think that is everyone from a clergy member to, somebody in the billing office who happened to take a pro time one day. I mean, come on, you can't just blanket and say this person's a clinician. I actually had a physician say, well, my state doesn't have any rules on what medical assistants have to do. They just have to be, high school diplomaed, and they don't have to have any kind of certification or credential or schooling. Even we can just train them in the office, how to take blood, I'm like, how to take blood? Okay, you're killing me right now. How to do all this other stuff. And it drives me crazy, because then they say, and look, it says right here that we can do all this stuff under and just bill it as if the doctor did it. And it's really, again, my face planning is just getting, can you see the bruises here? It's just getting really tough, because some of this has to be common sense. And, and I'm not trying to be flip, and I'm not trying to be, condescending to anybody. I just feel like the more people try to get around the rules, the more that the rules have to be clearly, put in these contracts. One in particular, and then I'll throw it back to Scott, is that United Healthcare put out a rule at the end of the public health emergency, which I thought was funny. And they just said that you can't have telehealth in your car or in a place that isn't clean. Well, why did they have to put that in there? What were they seeing? Were they seeing, fast food bags in the back of your car? So I just thought, or were you going through Starbucks when you were getting your visit? So it's just interesting when you start to see contract language, OIG putting things out, CMS putting things in their policies. You're like, why did they do that? Everybody knows that. And you're just like, apparently they don't.
No,
So,
my son had a telehealth visit. He was on the beach, and the provider said, I'm not going to do it on the beach. You have to go sit in your car. Well, and now I know if he's got United Healthcare, he can't even be sitting in his car. So
in his car. And I know at some point it's because some people didn't have internet, which I think they put the cart before the horse with the whole telehealth thing. Get everyone internet first, even Starlink, whatever, before you say, let's do all this, because that created a lot of bad actors. But just when you see just the made up definitions and, just things that people aren't following the entire rules. And Sean and I actually, we'll talk about this in hashtag Terry Tuesday tomorrow, but just people pick and choose what rule they want to follow, and then they adjust the rules to fit their agenda. So Scott, I know you had a comment.
Yeah, I was just going to add to that how important I think this is, because when we were talking about assistant at surgery, to me, like, I see a lot of rules confusion between assistants at surgery and co-surgeons all of the time in terms of what the documentation requirements are. And I'm thinking of an audit I had recently where the patient was having multiple things done, and some of them had co-surgery modifiers were allowed, and some of them didn't. And the way this group was seeming to do it was they performed the co-surgery service, and then they split the rest of it almost like, well, we'll just divide this evenly between us in terms of who does what. But the problem was, like, they were documenting non-co-surgery codes almost in a co-surgeon's way. And so I'm looking at provider A and I'm saying, well, you did your part. And then provider B was saying, well, I picked up, I did the same thing as provider A, but it wasn't a co-surgeon code. And I said, well, unfortunately for you, like, this provider did everything for their non-co-surgery codes. You just played off that documentation, but as a consequence, you didn't meet the requirements from this. And that's before we get into, were you doing like a laterality split because you wanted to be fair to one another, but now when you're billing this to the payer, you're unbundling something that has a multiple procedure payment reduction. So you really have to understand what does sit behind all these codes. And life and medical billing is not always fair. And this was, I was trying to figure out what they were doing when I first started looking at the charts. And eventually I said, well, okay, they're doing the co-surgery stuff, but then they're basically looking at everything else they're doing, and let's just split it so you get this and I get this, and then we can come out and say it's even. But it really was not. It had zero correlation to what the best care possible was for the patient. It potentially was resulting in unbundling of things that would otherwise have been reduced on a multiple procedure basis. And even in the co-surgery part, instead of each documenting their own piece, they were basically documenting like, well, this is what we did, and we'll just kind of document it together. So it's important to understand those distinctions, even when you say to yourself, well, this is this, so I'm allowed to do it this way, and this is this, and I'm allowed to do it that way. You still have to understand what's necessary for the patient and how it's being foundationally documented based on what those important differentiators are between either modifier types or various status indicators associated with the services.
Well, Scott, I actually had, I don't, sometimes I think that life is a parody for me when it comes to auditing, because I had doctors that they have these, there's this one huge practice that I'm dealing with, and they have surgery rooms that are kind of lined up together. And actually there's speakers in the room so they can talk to each other if they want to. And the physicians were saying that there's a couple of surgeries, they're anterolateral approaches, and they had to be co-surgery for what they were doing for the spine and the corpectomies. And they said, well, what we do, I don't know why people say this out loud. What we do, Terry, is we put a nurse practitioner in there that's a first assist, but because we could talk to each other, through the rooms, we just direct them on how to do the co-surgery. And then that way we can bill as co-surgeons. Otherwise we can't get this paid that way. And they just kept going on and on and on. I'm like, that's not incident to, like what Christine was saying, some of these codes have a specific value and definition behind them on what you can do. I said, who told you they could do that? Okay, what do you guys think the response was? Well, we heard from nobody, apparently. We heard from someone that we can do it that way because we can talk to each other in between rooms and we're under the same roof. And it just kept going on. And I'm sitting there and it was getting really
Well, as long
warm
as
in
they
the
had
room.
the door open, it was okay.
I know, right? I've seen that
This
too,
reminds
Sean, where
me,
I
if
got an ASC attached to an office, and they say, well, we're doing a breast biopsy and the ASC attached to our office, but we keep the door open so we can still get the incident to money from our PA seeing patients in the clinic. And I'm just like, I need to go back to what I really wanted to do in life, and that was to be an NFL, scout. I just think that I need to scout for NFL
well,
teams.
I think it's funny. I think that we lose focus when we start talking about healthcare, because if I'm driving Sean's car and Sean says, okay, hit the NOS, Christine, we're going to go 200 miles an hour, and I get pulled over, can I tell the police officer, Sean told me to do it, it's his car? I mean,
Of course you can.
I was
No.
speeding under the direction
Yeah,
of
and the
Sean Weiss.
direction of
Right.
Sean Weiss.
Yeah.
That's
Now,
awesome.
no one
Incident
will
two.
ever.
I'm,
We're
now,
I
all
was,
if you were
laughing
in,
about it.
I'm
but that's
operating
what-
under a speeding plan of care created by this person in the back right.
now,
Right?
if you're in Troup County, you may or may not get away with that.
Oh, well, see, but do you think we're all sitting here laughing about that, and shaking our heads, but what Terry's saying is true. That's the same answer that we're giving essentially in healthcare. Oh, well, so and so's doing it down the road, or they told me that it could be, we can do this. The craziness is it's the same concept. Who is it? Where is it written? Show me that. Again, you're going to be, you can't use that as a defense. So and so told me to do it. So and so's doing it down the road.
Well, Christy, and I'm getting the same thing from, I mentioned before, the third-party payers with I mentioned on a different podcast about some incident to things and relationship. I'm getting a lot of these third parties coming to me saying, yes, but I read that the virtual supervision is going to be put in permanently. I'm like, well, it depends politically who's in office. But they're saying that this is going to possibly be extended permanently. I'm like, why would they do that? They already said
possibly.
They said it was a safety issue. They already said it was a safety problem.
Right.
So now if they put it in there, it's like, did the safety issue go away
I
from
do
not
want to
being
say one
immediately
thing,
available?
and here's the reason why I think it won't. Because
I
a
hope
lot of
not.
folks don't realize that under the False Claims Act, safety and deplorable care are things that actually could rise to the level of the submission of a false claim. So,
Well, Sean, wasn't the intent of doing virtual care in the height of the pandemic because of what we were dealing with in the hospitals and we needed to
that's right.
support the residents? It
That's
was
right.
about residents. It wasn't about, everything else that they're trying to put it under.
I will say one thing, and then I want to go to Stephanie because she's got our last topic of the day. The number of post-pandemic audits, investigations, and settlements that are going on right now is highly concerning to me. And I mean this very seriously, and I want people to hear me say this because I am somebody who's on the front line every single day with these kind of cases that are being brought by different government entities. There is no doubt that during the public health emergency, there were some bad actors. Some, but it was a minuscule number of people. 99% of all providers out there did the best that they could do with the information flows that were coming at them, with the staff shortages that they had. They were doing, listen, while everybody else was running away from the pandemic and trying to find a rock to hide behind, these providers that are now being hammered for no good reason were running towards the danger. And it is mind-boggling to me. I am in the process right now of writing a independent report to a prosecutor in helping them to understand why the case that they are considering bringing against this provider would be an absolutely horrific call. Not only are you going to be able to not convince a jury of reasonable people that this doctor did anything wrong, you're going to have a hard time convincing people to convict a physician who sacrificed everything, moved out of his own house during the public health emergency, took up an apartment so that he could continue to render care to patients and not subject his family to danger. I have a hard time with somebody who is not a career prosecutor trying to extract a pound of flesh to hang on their wall so that one day they could get a big fancy corner office in a mainstream law firm. Don't do it.
Yeah.
Let's give the respect to all of these first responders, these providers. Yeah, there's some bad actors out there, and you can go after them. But give these providers who were struggling with inconsistent, at best, information coming out during the public health emergency, garbage information. Think about this. The American Medical Association had to do a complete retraction on their published information because it was non-compliant with federal guidelines and what the Centers for Medicare and Medicaid Services put out. Myself and one of our employees from Doctors Management actually were retained to audit commercial insurance companies to determine whether or not they were in compliance with federal law. And guess what? They weren't.
Right.
So why are we not looking at the insurance companies? Why are we allowing the insurance companies to deflect and go after these providers?
Well, also, Sean, there, one of the things that's happening right now is some of the audits I'm dealing with some of the MAC carriers
Yeah.
is they're saying that, well, that wasn't the spirit of the rules. I'm like, wait, what?
Yeah.
You say you're not
Don't
going
even
to
get
just,
into the spirit of
yeah,
anything
they
with me,
and
because
they're making their case. They're taking money back from
of course they
providers
are.
saying you are applying this rule wrong. This is not the spirit of the rule. So you're not even, and Christina and I brought this up several times. You don't just need to know what the federal rule is, what your
That's right.
and what the payer contract says, but state supersedes anything that the government says. And you have to know, especially in Florida. Florida is like California's second, but especially in Florida, you've got to be careful
Yep.
because what supervision rules everywhere else, and then there's Florida.
Yep.
And Florida is very specific. So are we in California about what mid-levels, what clinical staff can do. And they're like, yeah, but Medicare says. I'm like, okay, stop saying that.
Well,
I realize
we follow Medicare rules for Medicare beneficiaries, but everybody else, we need to follow state law.
State rule. Yeah.
Okay. Stephanie, let's go to you and let's get our last topic in for today.
Okay, so this was already touched on a little bit, really by Scott as well, when you were talking about, the differences with the surgeons and what that looks like. And last week I had a situation that was pretty frustrating because I was dealing with a surgeon, and on the audit, I was like, okay, he is undercoding, so he should be happy because we're going to talk about modifiers and how he's missing out on reimbursement and all of this. And I go through the whole spiel. He's a spine surgeon. And in the larger cases, they will typically work. One does the left side, the other does the right side. They work together. And he immediately was like, yeah, I know. I was the co-surgeon. And he had a beautiful note too. That was the crazy thing, because usually when I have to have these conversations, it's me not supporting assistant or co-surgeon because we don't have enough detail. He had a beautiful note. Both him and the other surgeon documented their portions of what they did. There were no issues. And he says to me, well, I do it that way because if I do co-surgeon and put those modifiers on the claim, then my partner is going to get paid a lot less. So we've decided that we're going to take turns. And sometimes I do this and sometimes he does that. And, we had to have a whole conversation about how, again, what you all were just saying, it's not about the reimbursement, it's about compliance. And your note clearly shows that you're a co-surgeon. You are not just an assistant here. You are operating on the whole one side of the body.
What if they want documentation, Stephanie? How
I
are they
know.
going to support that one doctor did all the work if documentation has to get submitted? It's just crazy.
And
But
here
the
I just
value of
gave
the
this
code,
whole,
the
I just
value of the
gave this
code is
whole
because of their
spiel
co-surgeon.
about minuscule bad actors, and come on, man.
Sorry.
Yeah, but Stephanie, did you talk to them about some of these codes are priced when they need a co-surgeon because of the complexity of the case? That they're priced because they need co-surgery options. It can't just be one operator with an assistant. Oh my
That's
God.
what the
Well, and
indicator
that
on the
was
CPT code does.
Well, that was the other frustrating thing. He was talking about like all of the decisions for surgery. And it's like that is what that primary surgeon billed that E&M service for. And, on top of it, when you think about it, usually the workflow in these offices for any pre-op discussion or education after that decision, most of the time that's done by an APP provider, as well as the majority of the post-operative time and the monitoring during that period. So really, when we break it down and look at those codes, like you're saying too, Terry, it's like you're still getting the allocated money for what you're doing. And I had one other, again, spine surgeon last week, talked with his practice administrator, and he was frustrated because when he does the work on the anterior side, he needs ENT to come in and do the access. So he was frustrated when he saw what co-surgery gets for access, because he says, well, he just comes in and within 10 or 15 minutes, he's made access to the point, and then I do all of the work, but he gets to bill the primary because there's no separate access code with the modifier, and I think he's being paid too much. So, you know,
Not
he
his
was
call.
Why
That's
why
like that's
why
like the
why can't
abdominal
they
surgeon
use
coming in for an abdominal approach.
surgical
I know.
team?
Oh my gosh. Oh my
Well,
gosh.
Well,
in
I'll
that
tell you why.
situation, it's
Wait,
not necessarily a team. Go
Okay,
ahead.
fair enough.
so Stephanie, I just saw something on Facebook or LinkedIn or one of those social media platforms, and someone was advertising that you can become a medical biller with no higher education at all. So a high school diploma, if that, GED at that, and you can be a medical biller. And I think that providers need to realize that you're going to get what you pay for. I'm not going to go see my podiatrist and have him do brain surgery on me. He doesn't have that level of education and knowledge. I think the same thing. Providers need to make sure that they are hiring qualified, trained, seasoned coders and billers. And then, just as Debbie said in her comment on right there in the comments, fantastic. We rely on you to do good brain surgery, but you need to rely on that qualified staff member to come in and help you get reimbursed for it. It's not a free for all out there. There really is a huge science to the reimbursement of medicine.
Absolutely.
Sorry.
Well said, Christine.
I mean, I think anytime you're saying anything where you're like, we should do it this way, dot, 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 like the reason should only be because that's the compliant way to do it. It shouldn't be because this
Spot on.
affects the money. It shouldn't be because like this makes it more fair. It just because from a compliance perspective, this is the way we're supposed to do it.
Absolutely. All right. Well, I think this was a fantastic first roundtable coming back after 3 weeks of being off. I want to thank Paul Spencer, Stephanie Howard, Scott Kraft, Christine Hall, Terry Fletcher, in no particular order, for taking time out of their busy schedules to be here today. I want to thank each and every single one of you for tuning in, logging on, and hanging out with us for a little while today. We've missed y'all. We've heard from you all that you've missed us. So we're glad to be back. Terry and I are going to be back tomorrow with a brand new hashtag Terry Tuesday episode. Don't let the title of tomorrow's episode fool you. Make sure you listen to it all the way through. I am excited because when we come back in 2 weeks, I will be in a brand new studio. I am extremely excited. Uh, Lots that I'm going to share through the build out of the studio, the pictures and things like that I'll be sharing over the next week. So I am excited to be back with y'all in 2 weeks on our next Monday auditing, coding, compliance roundtable. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.